Hello, everybody, and welcome back. We've got some awesome practice questions for you today. Please like and subscribe, and let's get started. A 28-year-old male is a competitive cyclist, participates in a high-intensity interval training session. He performs multiple short bursts of maximum effort cycling, followed by a 1-minute recovery period at a slower pace. After completing several of these intervals, he experiences significant leg muscle fatigue and burning pain. Laboratory analysis after the session shows a temporary decline in the blood pH. Which of the following is the most likely contributing to his symptoms? All right, so the big takeaway here is we have a high intensity interval training, and that implies anaerobic metabolism. I used to play baseball competitively. We went around the nation, and I was a pitcher. And after I would throw, I remember one of the parents would always massage my arm, and they'd say, you got to get that lactic acid out. And there's actually a little bit of truth to that, right? In this patient, we saw a temporary decline in the blood pH, and so that's like the acid. That's the metabolic acidosis. And that's usually lactate because of the anaerobic conditions. The burning pain in the muscles is also classic for lactic acid buildup. And so during anaerobic exercise, oxygen becomes limiting. And so to keep glycolysis running, the only available ATP source whenever you're doing anaerobic exercise, the cells have to convert pyruvate into lactate so that they can regenerate NAD+, and that leads to the acid buildup. And so the big associations here are lactate dehydrogenase, LDH. That's the enzyme that's responsible for the pyruvate to lactate conversion. We should also know that this is going to be associated with your type 2B muscle fibers. They're fast-twitch, anaerobic, high lactate producers. And the Cori cycle is relevant here too. The Cori cycle is where the liver converts the lactate back to glucose via gluconeogenesis. And so you get that NAD plus regeneration, and it's super critical to sustain that glycolysis during the oxygen debt. And so you get exercise-induced acidosis, and it's self-limited, and it resolves with rest and reoxygenation. So the pathophysiology is very important here. First, you have the oxygen depletion during the intense exercise limits. Right? You can't breathe while you're doing that intense exercise, and so we're undergoing glycolysis. So we're limiting the oxidative phosphorylation that can occur. So that's the first thing. And the second step is super related to this. Glycolysis is all of a sudden now the very predominant source of ATP. And that's great, but this produces NADH as a product. And then we're going to convert this pyruvate, which is made through glycolysis, into lactate via LDH, and that regenerates NAD+, that allows glycolysis to continue working, right? Because you need NAD+ for this to work. And so you do pyruvate to lactate so you can go enter into glycolysis again. And then lactic acid accumulates, and that causes intracellular and systemic acidosis, which manifests as the burning muscle pain. So that's the reason why he has the burning muscle pain. That's the reason why the blood pH is low. That's the transient metabolic acidosis. And there's no oxygen. And that leads to glycolysis-dependent ATP generation. And you get the short bursts of the effort. And that's the type 2 fibers. Those guys are involved in anaerobic glycolysis. And so our answer is indeed going to be C, the conversion of pyruvate to lactate, regeneration of NAD+ in the muscle cells. So it's during the anaerobic exercise, the muscles rapidly consume ATP, oxygen delivery can't keep up, and so you switch to anaerobic glycolysis. Pyruvate is converted to lactate by lactate dehydrogenase, which regenerates NAD+, allowing glycolysis to continue. Lactate buildup causes acidosis, manifesting as burning, pain, and fatigue. So that's the reason why your legs feel like they're on fire after you do the big old sprint. Your muscles demand the energy quickly, oxygen delivery can't keep up, and so we switch gears to glycolysis, and it turns glucose into pyruvate. But to keep going with that oxygen, we have to convert it to lactate to regenerate NAD+, causing acidosis, fatigue, and pain. That's why you have that drop, muscle pain. It's the intense anaerobic exercise. Okay, in our next question, we have a 12-year-old boy evaluated for muscle weakness, episodes of confusion, and temporary vision loss on his right side. His maternal uncle experienced similar symptoms, and the boy has experienced difficulty keeping up in physical education class due to fatigue and muscle cramps. On physical examination, there is a right-sided hemiparesis and decreased visual acuity in his right eye. Laboratory studies reveal elevated serum lactate levels both at rest and after exercise. The MRI of the brain shows areas of hyperintensity in the occipital region. Which of the following is most likely genetic abnormality in this patient? The answer is mutation in mitochondrial RNA. And there are two main facts that we have to know to be able to answer this question. One, we have to know what MELAS is. Your mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes. So it's mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes. And this is often maternally inherited. That's why it says the maternal uncle has experienced this as well. This is caused by mutations in the mitochondrial tRNA, commonly with lysine or leucine, and that can disrupt oxidative phosphorylation. So maternal inheritance strongly points to a mitochondrial disorder. And the elevated lactate at rest and after exercise is going to be a clue for the defective mitochondrial metabolism. It's the same kind of thing as the last question. Here we have defective mitochondrial metabolism, which means you have more lactic acidosis because glycolysis is going to be relied upon to a greater extent. There are also some stroke-like episodes in a child, and that's due to the S in MELAS. Whenever you have a stroke in a child, especially without any vascular causes, then that should definitely lead to think of a mitochondrial cytopathy, because unlike ischemic strokes, the MELAS-related lesions don't actually have any respect for those vascular territories, and that's the super important clue on imaging. You have stroke-like episodes, lactic acidosis, and maternal inheritance. So here's the pathophys. You have a mutation in mitochondrial DNA, causing defective proteins for oxidative phosphorylation, decreased electron transportation function, so you have less ATP, and so then you have lactic acid from the anaerobic metabolism, and then the energy-demanding tissues like the brain and the muscle are going to have stroke-like episodes, even though it's not like that same vascular problem that you're used to whenever you have stroke-like episodes. And this most often affects like the posterior cortex, the occipital lobes, and can cause vision loss. And really, you're going to see the ragged red fibers on the biopsy, and that's because of the accumulation of the abnormal mitochondria. All right, and the next question, we have a 55-year-old woman participating in a research study investigating the relationship between dietary patterns and the development of hypertension. She presents with a medical history that includes type 2 diabetes, mellitus, and hyperlipidemia. Part of the study, she is asked about her regular intake of fruits and veggies and her consumption of processed foods. The study involves comparing groups of people with and without hypertension to determine if scientific dietary habits are associated with the presence of the condition. What is the most appropriate statistical measure to quantify the association between dietary patterns and hypertension in this study? All right, so there's our patient. She's got her fruits and her veggies. And what's important to know is that you cannot calculate the risk in a case control study. And that's because you've already chosen your outcome cases and controls before you even look at the exposures. And so here we're comparing people with and without hypertension, and we're asking them about their dietary history. And that is the hallmark of a case control. And so this is going to be an odds ratio. And this tells us how much more likely the cases were exposed to certain diets compared to the controls. And this one, you start with the odd person. That's the way I like to remember this. So they can then determine the likelihood or evaluate the likelihood of exposure of a risk factor based on whether or not they have the disease. Here, a 16-year-old girl is brought to the emergency department by her father due to confusion and difficulty walking for the past day. He mentioned that she had several episodes of dizziness for the last months and her grades have dropped significantly. On examination, she has nystagmus, dysmetria, that's whenever you can't touch the finger that somebody else is holding up on the finger to nose testing, and also a wide-based gait. Her speech is slow. She appears lethargic, but she is able to follow simple commands. She has no history of chronic medical conditions. Her father says they recently moved and she's been spending more time in the garage working on projects. Which of the following exposures is most likely responsible for her symptoms? Now, this is a really good question. Now, something that not a lot of people know is that inhalant abuse is one of the most underdiagnosed substance use disorders in teens, and it can actually mimic serious neurological diseases. So we have a 16-year-old, she's confused, ataxic, nystagmus, her grades are slipping, and she's been spending a lot of time in the garage working on projects, right? Sounds innocent, but this is going to be glue sniffing. It's glue solvent exposure. So it's usually the glue solvent. So this is toluene, and that's found in a lot of products like adhesive, paints, and also aerosols. And when you inhale it, it damages the cerebellum and the white matter. And that leads to the exact symptoms we see here: wide-based gait, dysmetria, slow speech, and confusion. Okay, so lead would be too chronic and it doesn't hit the cerebellum like this does. Carbon monoxide would be the wrong exposure pattern. Mercury is definitely not going to be likely in that group or the setting. And carbon monoxide, you'd probably think of like a headache, cherry red skin, a flu-like illness. That affects the globus pallidus, not the cerebellum. And asbestos would have the pleural plaques and mesothelioma. That's more of a pulmonary carcinogen. And mercury would have like a tremor or psychosis, and that would cause peripheral neuropathy, but not these cerebellar signs. That's the glue solvents here. All right, in this practice question, researchers are evaluating the relationship between smoking habits and COPD. They enroll people with different smoking habits and they see what they have. And so this is going to be a cohort study because they're analyzing the relative risk. Relative risk always goes with cohort. You just have to kind of memorize this. I'm going to get to the bottom line really quickly because this is super easy. Cohort, relative risk, impact of COPD incidence over time, but they're assessing smoking's impact. Case control, you start with the disease. Case series, descriptive collection of things. Cross-sectional is a snapshot in time, and randomized control is the gold standard. Super easy question. Free points on test day. Relative risk goes with cohort. Okay, for this next question, we have a 20-year-old female presents to the clinic with primary amenorrhea. She reports normal breast development starting in age 12, but has never experienced menstrual period. She has noted little to no pubic or axillary. On examination, the patient is tall, with a height of 182 centimeters. Physical examination reveals normal appealing female external genitalia, but no palpable uterus is noted on pelvic exam. Serum hormone levels show increased testosterone and luteinizing hormone. Which of the following karyotypes is most likely present in this patient? Very interesting question, right? So let's do a quick lay of the land. But the way to think about this one is girl on the outside and then guy on the inside. So amenorrhea is going to be commonly occurring in step 1 as a question. And the first question that you should ask is the uterus present or is it absent? If the uterus is present, then you think about the outflow tract tissues, like an imperforate hymen, transverse septum, that kind of stuff. If the uterus is absent, then all of a sudden you're thinking about Mullerian agenesis, right? That's the 46XX, and you have normal pubic hair versus androgen insensitivity, and there you have scant pubic hair. And so the case here, we have a couple of conditions that we just have to note. And this is the best way to think about this is the uterus present or not? So the uterus here is absent, and then breast development, and then also minimal pubic hair tells us that this is androgen insensitivity. So that absent uterus, that helps us understand if it's Mullerian agenesis or androgen insensitivity, right? We know it's going to be one of those two things. The scant or the absent pubic hair is going to be the hallmark of an androgen receptor defect, and then tall female phenotype with an XY karyotype is going to be androgen insensitivity, and that's why the answer for this question is. So in genetics, how this typically will show up is we have an X-linked receptor or an X-linked recessive mutation in the androgen receptor gene. And typically you'll see elevated LH and elevated testosterone. Why? Because it's in the male range. And also you have elevated estrogen from the aromatization that occurs. So the pathophys, you have a mutation of the androgen receptor gene, so the body cannot respond to testosterone or to DHT. That's usually what's happening here. And you have anti-Mullerian hormone from the Sertoli cells. And that causes the regression of the uterus and the fallopian tubes. That's why you do not have those when they're on physical exam. And the testosterone is aromatized into estrogen, and that's why you get the breast development. And there's also this effect of the lack of androgen-dependent hair growth, right? There's no internal male structures because there's no DHT signaling. And so there are some people, and this is where I kind of get frustrated at like the scientific illiteracy in the population, just because they don't allow for some basic biological facts. Just as Homo sapiens, we need to know that some people can have a male karyotype, but then they look completely female. And that is complete androgen insensitivity hormone, androgen insensitivity syndrome. And so typically the way this presents is you have somebody who's like relatively tall, maybe like 20 years old, and they have primary amenorrhea. They have normal breast development and no uterus on the exam. And there's actually an episode of House that I think was very interesting where somebody had this syndrome where there's very little pubic or axillary hair, and the labs are showing high testosterone and high LH. And so the breast development means, okay, then we have some estrogen that's hanging around there, right? And where's that coming from? Well, the answer is it's the testosterone is being aromatized into estrogen, but the androgen receptor itself is defective. And so testosterone itself cannot drive the male development like it would if you did not have this condition. And that explains also the absent uterus, because Mullerian inhibiting factor was secreted by the Sertoli cells. It also explains the normal breast, but in the scant body hair, because that would require the androgen action, but that receptor is broken, so you can't do that here. And so testosterone is produced normally from the functioning testes, right? But because of the androgen receptor being defective, the hormone cannot exert its masculinizing effects. And so you get a big old portion of that testosterone is aromatized into estrogen, and that drives the breast development in these patients. And so they're going to be phenotypically female, even though they have the karyotype of a male. So the chain is basically of the testes to testosterone, which cannot act on the receptor, and then it's aromatized to estrogen that causes breast development. So here's the bottom line. Primary amenorrhea with normal female genitalia and elevated testosterone suggests 46XY karyotype indicating androgen insensitivity hormone syndrome. All right, in our next practice question, we have a 54-year-old woman presenting to her primary care physician with complaints of chronic joint pain, recently worsening fatigue, and a 15-pound unintended weight loss over the past 3 months. She also mentions that her skin has become darker over the past year. Maybe that leads us to think of bronze skin. Her father had diabetes and died of liver disease. Yep. On examination, the skin is bronze. She has palpable tenderness over the second and third metatarsal joints. AST 95, ALT 102, ferritin is at 1,500. Total iron binding capacity is 180, and transferrin saturation is 85%. Liver ultrasound shows mild hepatomegaly. Which of the following is most likely the pathological process causing this patient's condition? All right, there are some classic triads that we should be aware of. One is that we have bronze diabetes in the skin. We have the hyperpigmentation, diabetes, and liver disease, right? That's the triad. The skin hyperpigmentation, diabetes, and liver disease. That is hemochromatosis triad. And the pathogenesis is this genetically increases the intestinal iron absorption, and so the answer is going to be D. So the lay of the land here is that we have a primary complaint of chronic joint pain. They got the joint pain, they got the weight loss and fatigue. And on exam, you see the bronze skin and the tender MCP joints and the hepatomegaly. There's elevated AST, very high ferritin, and low total iron binding content, and a high transferrin saturation. And all of that points to iron overload. It's a disorder that's caused by the increased intestinal absorption of iron because you have a mutation of the HFE gene. And so really, the big takeaway here is that bronze skin, that's like very pathognomonic for this. The increased melanin causing that hyperpigmentation. And also the diabetes and the liver disease, bronze diabetes. And that's caused because the iron damages the pancreatic beta cells and the hepatocytes. And you can also have MCP joint pain. And that's because of the pseudogout. You get the arthropathy, which basically is just like, anything that affects the joints, arthropathy. And that's because of the calcium pyrophosphate deposition and the increased ferritin, increased transferrin, and the decreased TIBC is the hallmark of iron overload. And so there is an HFE mutation. It's a gene mutation, and it has some comorbidities. There's hepatocellular carcinoma risk. It's 200 times increased. There's also the restrictive and dilated cardiomyopathy and testicular atrophy. And the epidemiology is that there's an autosomal recessive disease, and it's more common for people of Northern European descent. So you get the mutation, and then the enterocytes, the gut cells, they sense the low iron. And so they increase, and this is a little bit beyond the scope, but DM21 and ferroportin, and that increases the iron absorption in the intestinal cells. And that causes iron overload, and that deposits in the parenchymal cells, right? The functional tissue cells, like in the skin, the joints, the heart. And you get reactive oxidation species formation and organ fibrosis, which leads to cirrhosis and diabetes and cardiomegaly. And so you get bronze diabetes and cirrhosis and cancer risk. All right, so here is the bottom line. Genetically increased iron absorption leads to hemochromatosis, causing joint pain, fatigue, and skin changes. And the next question, we have a 3-day-old newborn girl brought to the emergency department by her parents due to increased lethargy, poor feeding, and vomiting. The infant was born at term via uncomplicated delivery and initially did well on the nursery. On examination, she's sleepy, minimally responsive with mild lab studies reveal elevated blood ammonia levels and metabolic acidosis. Urine analysis shows increased excretion of orotic acid, and a genetic analysis reveals a mutation consistent with the disorder affecting a specific enzymatic step. Which of the following conversions is most likely impaired in this infant? All right, so we have a neonate, which by the way is just a way of saying a newborn child, or it could actually be like any mammal that's newborn. And they have vomiting, lethargy, so they have a lack of energy and enthusiasm. They got elevated ammonia, and so you got to think of the urea acid cycle, urea cycle disorders. And this is probably like an OTC deficiency. We have high ammonia, and that's obvious because the urea cycle is blocked. You've been blocked. And erotic aciduria, that's excess carbamoyl phosphate that's shunted into the pyridamine synthesis pathway. And also there's no megaloblastic anemia, and that distinguishes this from hereditary erotic aciduria. And so the enzyme step affected is transcarbamylase, and that's the conversion of carbamoyl phosphate and ornithine to citrulline. And the most important kind of buzzy words here is that there's a 3-day-old with vomiting, lethargy, and that means that it's probably some sort of a metabolic disorder. And so we have increased ammonia and metabolic acidosis, and that means that it's a urea cycle defect. And erotic acid in the urine means that we have excess carbamoyl phosphate that diverted to the pyridamine pathway. And the lack of anemia means that it's not erotic aciduria or like a UMP synthase deficiency. OTC deficiency is X-linked recessive, and basically we have that OTC problem, and then that leads to the carbamoyl phosphate accumulation, and then overflow then goes into pyridamine synthesis, and then that increases the erotic acid in the urine. So the urea cycle is blocked, and that causes the ammonia buildup, and that's neurotoxic. And if it's a UMP synthase deficiency, then you would see loblastic anemia. So for this type of question, you're going to see newborns that are totally fine at birth, but then they start to have vomiting, lethargy, and high ammonia. And it's because of that urea cycle disorder. And it's important too because they have erotic acid in the urine, and that means that carbamoyl phosphate is building up and it's spilling into the pyridamine synthesis. And so that's the supersignature look, like the diagnostic criteria for ornithine transcarbamylase deficiency. And that's why our answer is our citrulline to argininosuccinate. And all these other options aren't going to explain erotic aciduria with hyperammonia. So here's your argininosuccinate right there, carbamoyl phosphate synthetase, and your ornithine transcarbamylase leading to this. So it's that citrulline to argininosuccinate right here. So they're asking which conversion is most likely impaired in this infant. The big thing to know about the urea acid cycle or the urea cycle is the carbamoyl phosphate synthesis 1 is the rate limiting step. This part occurs in the mitochondria, and this part is in the cytoplasm. So here's a really nice photo, a really nice diagram of what occurs in the mitochondria and what goes out to the urine. This is the whole pathway, starting with this rate limiting step right here, carbamoyl phosphate synthase 1. You start with ammonia, and you get carbamoyl phosphate, argininosuccinate to arginine to ornithine. And there are enzymes that govern each step. And so when you're dealing with the urea cycle, hyperammonia is going to explain the lethargy, the vomiting, the poor feeding, and the carbamoyl phosphate shunted into the pyridamine synthesis will produce excess erotic acid. And so this step right here is the one that's kind of damaged. All right, and our next question, we have a 60-year-old male presenting to his PCP with difficulty holding liquid in his mouth while drinking, which began following a recent dental procedure. He notes that the left side of his face feels weak. On exam, there is decreased movement on the left corner of his mouth, and the patient is unable to completely close his lips on the left side. There are no sensory abnormalities in the face. Which of the following cranial nerves and branches is most likely affected? Boy, we love those cranial nerves, don't we? So it seems like there's some facial expression weakness without any sensory loss, and so we're probably dealing with a motor branch, and we have cranial nerve 7 with a motor branch, and there's difficulty holding liquids in the mouth. So that's probably an orbicularis oris weakness. That's the facial nerve. And so anytime a patient is presenting with unilateral facial weakness, the first step is to ask, is it motor only, like the cranial nerve 7 motor branch lesion, or does it also involve sensation? And there you could think of maybe the trigeminal nerve, cranial nerve 5. But here there's no sensory loss, and that rules out the trigeminal nerve divisions. And that's how we know that it's not the trigeminal nerve here or the trigeminal nerve there. So B and D are now out. And now taste is also not mentioned, and so the chordae tympani is not going to be the culprit. And there's also weakness localized to the lower lip area, and that's the marginal mandibular branch of cranial nerve 7. And so there's a weakness of the lips, you can't hold in liquids, and so that's the orbicularis oris dysfunction. There's no sensory deficit, and so it's not going to be trigeminal. And that history of the dental procedure means that the local anesthesia can actually injure the nearby facial nerve branches. So there are some associations you should know on tests, say like the buccal branch of the cranial nerve 7, and that controls the the upper lip muscle. And then there's also like the lingual nerve, right? The cranial nerve 5-3, that's the tongue sensation on the anterior 2/3 of the tongue. And the chordae tympani is cranial nerve 7, that's the taste anterior 2/3 of the tongue, and the parasympathetic to the submandibular and the sublingual glands. So those are some other nerves that are high yield and come up all the time. But here the pathophysiology is that you go to the dentist. I am your dentist. I was in Little Shop of Horrors, and I just think of that every time I think of a dentist. But basically, there's a local anesthetic or some sort of dental trauma that damages the marginal mandibular branch of cranial nerve 7. I'm going to have to ask my brother about this. He's in dental school. And there's a loss of motor supply to the orbicularis oris, the lower lip muscles, these guys right here. And the patients cannot keep their lips sealed, and so the liquid is just going to be dribbling down their mouth. And so there's a cranial nerve 7 motor lesion, and there's difficulty holding the liquids in. No sensory loss rules out cranial nerve 5 involvement. So the big thing, lower lip muscle, motor nerve, cranial nerve 7, marginal mandibular branch of the facial nerve. And that's our answer, E. So it makes it so you can't seal your lips, and so the drinks will leak out. All right, in this question, we have a 3-year-old girl is brought to the clinic by her parents due to persistent coughing fits. They describe the child as having episodes of intense coughing followed by a high-pitched whooping sound when she inhales. The child has a recent upper respiratory tract infection. Vaccination status is not up to date, and her parents have delayed some immunizations. On examination, the child is alert but periodically has paroxysms of coughing. Lab shows leukocyte count of 28,000 with 65% lymphocytes. Which enzyme is likely upregulated, leading to the dysfunction in the immune response due to the increased cyclic adenosine monophosphate levels, the CAMP levels? All right, so let's talk about whooping cough and CAMP stuff. So the classic paroxysmal cough with the inspiratory and the lymphocytosis in a child without full vaccinations is going to be Bordella pertussis. That's why you got to get your vaccinations, folks. Here, Trump recently announced that Tylenol is linked to autism and said he shouldn't even use it. And he couldn't even say acetaminophen. I mean, it's just scary when somebody that incompetent is in charge of actual health concerns. The problem is that in order to understand the mechanism of action of acetaminophen, you have to know a lot of other things. Like, how do you talk about the NAPQI accumulation and glutathione reduction only in excess to somebody who doesn't even know where the liver is? Anyways, I digress. The pathogenesis here is the pertussis toxin. ADP ribosylates the GI protein. So basically it adds those ADP ribose moieties to that target molecule, and that will inhibit GI. So you get uninhibited adenylyl cyclase inhibited activity, and so you get increased CAMP, and you have impaired phagocyte function. And the lay of the land here for Bordella pertussis is, of course, you have that cough, the paroxysmal cough and the inspiratory whooping sound, and also the marked lymphocytosis, and you have incomplete vaccination history. So those three things are the biggest ways that they'll test you on this on step 1. And the key mechanism you also have to know is increased CAMP. It's the increased intracellular CAMP levels in the immune cells, and that paralyzes the ability to phagocytose and clear bacteria. So whooping cough, paroxysmal cough, that's the repeated like machine gun coughing fits. Lymphocytosis, an unvaccinated child means that they have a high risk for this. And so there's a pertussis toxin that disables GI, and it increases CAMP, and it impairs neutrophil recruitment. Adenylyl cyclase toxin directly increases CAMP, and so that's like an association you should definitely know. And there's some complications here like pneumonia, seizures, encephalopathy due to hypoxia. And to prevent this, you just give them the DPAC vaccine, right? the DTaP vaccine, because that will contain acellular pertussis antigens, and so you're good to go. But you have the pertussis toxin, and then the ADP ribosylates the GI protein. The GI inhibition leads to unchecked adenylyl cyclase activity that increases the CAMP inside of the host cells, then impairs phagocytosis, causes massive lymphocytosis. Sorry, I think I said that wrong. It impairs phagocytosis and causes massive lymphocytosis, and that leads to a persistent infection. So that pertussis toxin increases the CAMP, get whooping cough, vomiting. You just got to get your vaccines. All right, and so the answer is going to be adenylyl cyclase. Good question is, why is it not catalase? Well, catalase breaks down H2O2, and so it's relevant in chronic granulomatous disease, not pertussis. Lactate dehydrogenase is a marker of cell damage, and it's not actually involved in pertussis. G6PD. A deficiency there causes hemolysis with oxidative stress, not coughing and lymphocytosis. And superoxide dismutase is an antioxidant defense not related to the pertussis toxin. So it's really that just pertussis toxin sabotaging the immune cells by the ribosylation of the GI protein. And normally the GI breaks the adenylyl cyclase. But when that's disabled, the adenylyl cyclase just goes wild, like crazy. And now you get like insane levels of CAMP in your system, and that paralyzes the phagocytes and it prevents the bacterial clearance. And then you get lymphocytosis during a bacterial infection. All right, I think we're ready for our bottom line. Whooping cough in an unvaccinated child is due to Bordella pertussis, which upregulates adenylyl cyclase and increases CAMP levels. So I know this is just an AI-generated kiddo, but holy cow, vaccinate your children. The biggest risk factor for Bordella pertussis is stupid parents. And we'll see you guys. Oh, I might actually make another song if you guys like that. Kind of a fun way to kind of recap all of these questions. It's kind of a fun way to make sure that you get the key facts from these last 10 questions. So I'm going to go ahead and make that song for you guys. If you think this is helpful, if you like this content, please like and subscribe. If not, let me know how I can improve. I'm always trying to improve. My goal is to help you pass step 1, step 2, and increase both the quantity and quality of content out there that'll help you prepare as affordably as possible. We got to increase scientific literacy in this country. So without further ado, please enjoy the song.
Fibrosis in the skin, heart stiff inside. Diastolic compliance takes a dive. Bone pressure rises, vessels constrict tight. Coronary resistance climbs in the night.
Fast twitch fibers, oxygen low, radiate your nanlus, glycolysis flow, pyruvate the lactate, acid builds fast, burn in the quads, but the energy lasts. Mitochondrial code from mama passed down. tRNA mutation makes the body shut down. Stroke like seizures, lactic acidosis, flame, ragged red fibers, Miller's is the name. Miller's
50 over 30, 300 over 7. Multiply it out, the retro's 3.8 heaven. Case control style, odds not a risk. Know the formula clean, that's a test maker's trick. Glue sniffing teen with confusion and sway. Broad basic gauge, school grades decay. Cerebellum hit, headaches in time. Bronze skin's not here, it's solve and grind.
Follow the groups, exposure's the key. Exercise halves and miles you see. Relative risk from incidents known. Cohort design when outcomes are shown. Androgen insensitivity, 46XY but looking like she. No uterus inside but breasts you see. Testosterone aromatized, hair is scarce, AI's answer. Genetics unfair.
Hemochromatosis, iron overload, bronze skin shine, cirrhotic liver, pancreas decline, H5 mutation, gut absorbs too much, ferritin high, joints hurt to the turn.
On the team can't meet, carbon oil fake. Erotic acid rises, ammonia's great. Baby lethargic, seizures might hit. OTC deficiency, urea can't fix it. Paroxysmal cough with the whooping tone. Unvaccinated kid, white count grown. Pertussis toxin, G gets fried. Adenylyl cyclase, camp worldwide.